Hello and welcome to the Feeling Good podcast. I am your host, Fabrice Nye, and joining me here in the Murrieta studios is the creator of the team model, Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. So David, today is part 2 of our podcast on the agenda setting, A equals agenda setting part. And last time we talked about what is resistance, the 8 kinds of resistance. And I'm sure that people are kind of eager to understand. So now that we know what resistance is, what do we do about it? So we're going to talk about, the actual paradoxical agenda setting and how do we do this today, right?
Absolutely, and it's to me a phenomenally exciting theme, because if you learn how to melt away the patient's resistance or the client's resistance, whatever word you want to use, it opens up the door for some, in many cases, phenomenally high-speed recovery. I just got back from Canada as well. We've had a little hiatus in recording here. We skipped last week. And I did 2 4-day intensives on team therapy. Mm-hmm. And as part of it, I did a live demonstration at each workshop and had volunteers who'd had very severe feelings of depression. One for women for 40 years.
Wow.
And in both of the demonstrations, there was a total elimination of these individuals' symptoms. Both were about 2-hour demonstrations that included teaching for the group while I was treating these individuals. Mm-hmm. And it was really because of the what we call paradoxical agenda setting, melting away their resistance to change. And it was extremely clear in one of these cases that if I had not done that, I wouldn't have made any progress at all, because the woman was pretty determined to cling to her symptoms of guilt and shame and depression. And then I also worked with many other of the therapists. We would go hiking in the evenings, and we did personal work on things. One was a young guy, and he just broken up with his girlfriend, and he was telling himself, I should be further along by now, a theme we've often heard from people. And he was lonely and kind of beating up on himself. And in those cases, the people really recovered within. I mean, this is going to sound ludicrous to say this, but it is a fact, and that's why I'm reporting that they recovered completely from their feelings of depression and guilt. A number of them, each of them,
and that's rather amazing.
But it took about 20 minutes. Is my point.
Yeah,
and it was just a combination of condensed paradoxical agenda setting, followed by a technique we'll do in a future podcast, externalization of voices.
Yeah.
And it was really mind-boggling.
So I think by now our listeners are really curious to find out. So how do I melt this resistance? I'm
not going to tell.
Okay, all right. So next.
I'll give an example of it, but each patient, it will be done differently.
Yeah,
and it's different for depression versus anxiety versus angry people with relationship problems versus habits and addictions. But I'll try to give a vignette to kind of bring many features of paradoxical agenda setting to life. There was a young man, and I always disguise the identities and the names of people. But let's say his name was Ramesh. He was a computer programmer from India who was living in Philadelphia, and he came to me And the initial testing I did before I even spoke to him, just with the brief mood survey, indicated he had severe depression, severe anxiety, and severe to extreme feelings of anger. And so after I took his history, empathized, formed a kind of a connection with him, I asked him, and he was very upset about a lot of things in his life and a lot of things at work, and I asked him what we call the invitation step.
What is that?
That's where you ask the patient, after you've empathized and you've got a good connection and the patient feels understood and gives you an A on empathy, they feel accepted, and you see how they're thinking, how they're feeling, and you ask the patient, is there something here that you want help with? Because sometimes patients, clients, whatever word you want, are just wanting to talk and they want to be listened to. They're not trying to change anything in their life. But in this case, Ramesh said, yes, he really did want my help. Mm-hmm. And I think he probably picked up a copy of the book Feeling Good and was, hopeful that I could use some of these techniques with him. And so then I did the next step of agenda setting, which we call specificity, and it's based on the idea I can only help a person for one moment in their life when they were upset. I can't help people on a general level, like so many therapists will try to be changing some general pattern in a patient through general talk about childhood or parents or whatever. This is radically different. And I said, but I'm glad, Ramesh, that you want help. Which of the many problems you've been talking about would you like to work on first? And he said, well, my low self-esteem. And then I did the second half of the specificity step is, can you give me a moment when you had that problem?
So the specificity, the first part is which of the problems, and then the second part is when did it happen?
Yes, and so he said, well, Dr. Burns, I had low self-esteem yesterday morning at 9:30.
That's very specific.
Yeah, that's very specific. So
like right now I'm okay, but no, yesterday morning it was bad.
Yeah. So I said, well, where were you at 9:30? What was going on? What were you thinking? What were you feeling? And he said, I was just walking out of my supervisor's office, or his boss's office. And I said, well, what was the meeting with your boss about? He said, I got my performance evaluation. And I said, well, how was it? And he said, it was terrible. She read that the people on my computer team have been saying that I'm not a good team member, I'm not helping, I'm not carrying my weight, that I don't relate to people well.
That sounds pretty bad.
Yeah, and on, all these severe criticisms of his work and his relationships with people. And I said, wow, that sounds pretty upsetting, pretty disturbing. How did you react? What did you say to her? And he started getting very angry, and he said, I told her that it's unfair, that there's a conspiracy against me because I have long hair and dark skin and because I'm from India.
Oh, wow.
And because I'm smarter than anyone else on that team, and I should be the head of that computer team. I should be the head of the company, I told her.
Well, he had a chip on his shoulder, huh?
Yeah, and it's all unfair, and this isn't right. And I said, well, how did she react to that? And
One can imagine.
Yeah, he said she just ignored me, and she told me that if I didn't shape up, that I was going to be fired in 6 weeks. She put me on probation for 6 weeks, and I went out of that office feeling like a total loser. Mm-hmm. Now we know what he means when he says he has low self-esteem. We've turned it into something very specific that we can work on. Now the next step of...
And I'm sure most of us listening to this can even at a gut level identify with how he might have been feeling.
Oh, yeah. Now the next step is called conceptualization. One of the unique things about team therapy is you don't treat a diagnosis, you don't treat a disorder, you treat a human being for what they want help with, the moment they want help. And they can talk about any moment in their life, and could be any kind of problem going on. So what we want to do is conceptualize the nature of the problem. And there's 4 things to choose from to make it simple.
Wait a minute here. So you're saying that if somebody comes to me and say, doctor, I'm depressed, you're going to say, well, I can't treat your depression? I have to treat you? I mean, how would you present that to your patient?
Well, if they want help with the depression, that's a great thing. If that's the problem they want help with, then I would say, give me a moment.
This person wanted help with his self-esteem, for example.
Yeah, and that's like saying I don't want help with my depression, because low self-esteem is kind of a synonym for depression.
Right. Yeah.
But if someone says I want help with depression, it would be the same thing. So I'd say I'd love to work with you on your depression. It's one of my favorite things to treat, and I have tons and tons of powerful tools. But can you give me a moment you were feeling depressed, so we can zero in on what was happening at that moment?
Yeah.
Once you get the moment, you do your conceptualization, and there's 4 choices. The first choice, it might be an individual mood problem. That would be depression or anxiety or shame or inadequacy, inferiority, or any of the synonyms, panic, worrying, anything under the depression or anxiety umbrella would be an individual mood problem.
Yeah, mood problem, yeah.
The second possible conceptualization would be a relationship problem, conflict with someone, marital conflict, not getting along with a family member or neighbor or colleague or whatever. Third conceptualization would be habit or addiction, like overeating, procrastinating, alcohol, drugs, anything in that area. And then a fourth conceptualization would be, and it's probably not a good name for it, but non-problem. And by that I mean uncomplicated grief, where a person doesn't have any distorted thoughts, they don't need psychotherapy, they don't need Prozac. All they need is a chance to vent and cry and get the feelings out. I'm a little bit confused about the term. If somebody comes to me, which happens sometimes, saying, I lost my husband, he died, 6 months ago, and I'm feeling really depressed. I don't imagine myself saying to this person, well, this is a non-problem. It's not a good term, that's for sure. Grief that you see in the therapy office is usually complicated by distorted thoughts. For example, the physician whose brother committed suicide, I think I may have mentioned her on an earlier podcast, I'm not sure, but she came to me with suicidal depression because she thought that she had failed her brother, that she should have known he was suicidal the day he killed himself. And so she had self-blame and a number of distorted thoughts that were actually preventing her from doing healthy grieving. That would be complicated grief. But if a person has no cognitive distortions and they love someone and they're flooded with emotion, and there's no anger or guilt or anything like that's going on, then those emotions are healthy. They isn't something really that needs treatment. Sadness is a part of life, and it's a beautiful thing in a way that shows that we can love. If we didn't love, if we weren't filled with passion for life, we wouldn't have grief and sadness.
So that makes sense.
Yeah.
So to summarize, you said there were 4 conceptualizations that you talked about. So the mood issues, the relationship issues, the habits and addiction, and the, let's call that grief.
Complicated or uncomplicated grief.
Yeah. Now...
or uncomplicated grief.
In a way that seems... To me, that seems like it sounds a little bit simplistic. When you look at the DSM, there's like 300 plus conditions, and you're conceptualizing into 4 possibilities, one of which is not even pathological. So
Yeah.
can you say more about that?
Well, you could add more categories like, psychosomatic complaints like chronic pain, or kids with kind of neurologic or pseudo-neurologic problems who shout out loud and, grunt and involuntary things like that. But the neat thing about this conceptualization is this is what probably 90% of the people you see in a clinical practice will be struggling with and wanting help with, even if someone has a severe diagnosis like schizophrenia, which is a true brain disorder. Still, they rarely want help with hallucinations and delusions because they don't believe they have delusions. But what they generally want help with is depression or anxiety or a relationship problem. The same kinds of things. So at any rate, the reason you conceptualize it is because that's going to tip you off what resistance the patient's going to put up.
That's right.
And it also gives you a hint about what methods you're going to use to help the patient, because, and I teach in my seminar at Stanford and in my workshops 50 basic therapy methods. I use more than that, probably 75 or 100 or more, but there's 50 that I teach as kind of a beginner's toolkit.
Good start.
Some of those, good. And some of them work for depression really well. Others are suitable for anxiety disorders. Some are good for relationship problems, and some are good for habits and addictions. It's just not true that one size fits all. And so here we have Ramesh, and we want to conceptualize. He said he wanted help with low self-esteem, but now when he says what really went on, we see that there's a bit more to it. How would you conceptualize Ramesh's problem?
Well, definitely, it really sounds like there's a mood problem in a way, because he's feeling bad about himself.
Yeah.
Definitely some depression. Like you said, self-esteem is another word for depression. This hasn't surfaced yet, but I could imagine there may be some anxiety too about the future.
Super severely anxious on the initial testing.
Yeah,
yes, absolutely.
I'm going to lose my job. So definitely there's a mood issue here. At the same time, the way he responded to his boss was rather, from this perspective, a little bit unskillful, and so I imagine there may be some relationship issues too.
Yeah, and with his coworkers. So we've got three conceptualizations: depression, anxiety, and relationship problem.
Right.
Now, we have tremendous tools to help people overcome depression. Wonderful methods. Fantastic methods to help people and quickly get over almost any type of anxiety. And we'll be talking about these in the immediately upcoming podcast. We've got beautiful relationship tools. One of my books you didn't mention, Feeling Good Together, is my latest book, and it's all
I love
about
that book.
Yeah, it's all about conflict with people and what causes it, and how to turn it around.
Yeah.
Thank you for those kind words. And so he's got problems. We've got solutions. So we have a marriage made in heaven. So should we go ahead and cure him now?
Well, I know better, but I would say, oh yes, of course.
Yeah, that's what I used to do in the early days, then I'd run into resistance and wonder why people were being so ordinary and unreasonable.
I'm here to help you. Come on.
Yeah.
Let me help you.
Yeah. So you have to think about resistance, and the way you work with resistance depends on your personality, as well as the tools that we've developed and what's going on with the patient.
Yeah.
But the common denominator is to let the death of the therapist's codependent ego, the therapist helping ego, the compulsion to help patients, the urge to help patients, while it's based on therapist compassion, is also the cause of nearly all therapeutic failure. And so with the new techniques that we've developed, the therapist instead becomes the patient. You turn into the patient's subconscious resistance and represent the resistance to the patient in a flattering way, with the idea that maybe they should not change. And you list all the good reasons for them not to change. And then what usually happens. I can't say it happens 100% of the time, but it's 90% of the time or more. Suddenly the patient's resistance disappears, paradoxically, and they have this incredible urge to work with you and to persuade you to work with them and to want to change. And if you want, I'll give you an example of how I did that with Ramesh.
Well, yes, because so far it looks like this fellow has not really expressed any resistance yet. So
he's just very hungry and eager. So
how did you get to that?
Well, what I said, Ramesh, is Ramesh, I'm so glad that you want help with these particular problems because I've got some fantastic tools, and I handed him a list that I've made of 50 ways to untwist your thinking.
And if I may interject, when you're saying to someone that you have some fantastic tools, you have a name for that.
Dangling the carrot. Yes, that's right. You dangle the carrot. That's one of the agenda-setting tools. So you're saying, here, I've got what you want, and I handed him this list of 50 techniques, and say you probably never heard of any of these tools, but they're very, very powerful. But the problem is, I'm not sure I'm going to be able to accept you as my patient, and that's not the message that most therapists give out this.
He must have been surprised.
Oh yes, he was shocked. He was taken aback. And he says, "What do you mean you won't accept me as your patient? That's unfair. These tools look fantastic. This is what I need. You've got to accept me as your patient, Dr. Burns." So now he's chasing me, and now I'm going to play the role of his subconscious mind. And so what I said to him is, "Well, Ramesh, don't get me wrong, but I'd love to work with you. I hope I can work with you." But there's this problem you've got to help me with first. And he said, "Well, yeah, I'll help you. What's your problem?" And I said, here's my problem. You see, for me to show you how to overcome your low self-esteem and develop better relationships with the people at work, you're going to have to do all the work. And you're going to have to work here in sessions, changing the way you think, learning to change the way you communicate with other people, and you're going to have to do psychotherapy homework an hour a day, 7 days a week, even if you're not in the mood, and you're going to have to work your butt off. Now, would it work? I'm sure it would. Would I love to work with you? I would love to work with you.
So you're addressing the process resistance that we talked about last time.
Exactly. But you see, Ramesh, here's my problem. It seems incredibly unfair to me that you should have to do the work when they're the ones who are screwed up. And some people would say, "Well, Ramesh, you're paranoid." But I know for a fact you're not paranoid because you have the evaluation of your boss, and it says right there that people are talking about you behind your back and bad-mouthing you. So it's a fact.
You have proof, exactly.
It's proof. And so what I'm saying to myself is, why should Ramesh have to change and do all the work when they're the ones who are screwed up? That seems to me to be unfair.
Yeah.
You see? And that's Ramesh talking. Do you see what I mean?
Yeah, because he's already thinking that, albeit maybe unconsciously, but...
Yeah, and to do this, the therapist also has to do what's called sitting with open hands, is give the patient permission not to change if that's where they're at. But this is frightening sometimes for therapists to use these techniques because it goes against the grain of their training, and it goes against the grain of human nature as well, because we so much want to help, reach out, and save somebody. Well, his response to that was, Dr. Burns, I hear what you're saying, but if you're willing to work with me, I'll work harder, I'll do more homework than any patient you've ever had. I guarantee it, and I don't care if it's unfair. I need these tools because, to tell you the truth, Dr. Burns, I was lying to you a couple minutes ago. I said, "Oh, you were lying to me. What were you lying to me about, Ramesh?" And he says, "Dr. Burns, my boss didn't put me on probation. She fired me. And then he started crying, and he said, "This is the 6th time this has happened to me in the last 2 years."
Wow.
And this was the early days of computer programming, and he says, those are the only 6 places in Philadelphia who use the kind of programming I do.
Yeah.
And if you'll accept me as your patient, I'll do anything if you'll only agree to help me change my life. And then I said, Ramesh, that's the message I was hoping to hear. And I just think the world of you. And I'm so grateful to have the chance to work with you. And he became the hardest working patient I've ever had. He started doing 6 hours a day of psychotherapy homework.
That's amazing.
And I said, "You're not allowed to do that. You can only work an hour, 2 hours at the most. The rest of the time, you got to look for a job." And within about 3 or 4 weeks, he had turned all of his depression around, and he had learned what we'll talk about in a future podcast, the 5 secrets of effective communication. Yeah. He worked his ass off, and he was a brilliant guy. And he just became a master with these techniques. And then he got a job offer in Florida, and he said, what do you think I should do? And I said, why don't you tell him that you'll only accept the job on one condition? And that's that your new boss would have to agree to sit down with you once a week for 15 minutes and criticize your performance. And then you can use these techniques, disarming techniques, stroking.
Yeah.
And he said, that's brilliant. So he called him on the phone and said, I'd love to come down and work with you, but here's the requirement. My new boss has got to agree to sit down and criticize me every week for 15 minutes, all the mistakes I've made, because I'm determined to become the best employee you've ever had, and that's what I need to get the job done. They said, "We've never heard of such a demand, but we're desperate, and we'll do it. We want to get you down here to Florida."
Wonderful.
And then he called me 2 months later, and he said, "Just guess who's been employee of the month for the last 2 months?" And they put his picture in the hallway, and he says, "My boss's biggest complaint is that he can't think of anything to criticize me about because my work and relationships are so great."
So quite a turnaround.
Yeah.
One thing that I noticed, when you were doing this agenda setting with him is, and I think you went over this a little bit quickly, but you did both the process resistance when you told him, he's going to have to do all this work.
Yeah.
You also told him that, also address the outcome resistance by, saying that, well, it's unfair that you would have to do all this work and let all those people off the hook.
Yeah. So
I wonder if you could separate the two and kind of give us the magical ingredient there that some people may wonder, how did that happen?
Well, the outcome resistance for depression, as we talked about in the last podcast, is a lack of acceptance, external acceptance or internal acceptance. And the internal acceptance is accepting the fact that we do make a lot of mistakes and we are flawed in a lot of ways. And then the outcome resistance for relationship problems is just maybe you don't want to get close to the person you're at odds with. I didn't have to address his outcome resistance because he was so desperate. He was so tired of being fired that he was tired of being at odds with the world, and he was saying, "I'm ready to connect with people."
It sounds that way.
Yeah,
but I just wanted for the
the process resistance, is to give up blame and accept all the responsibility yourself for solving the problem and pinpoint what you're doing that causes the other person, in this case the other people, to get ticked off at you. And that's what he said, that he was willing to change himself and do all the work. That was a beautiful thing. Let me just give you the quick conclusion of this story without getting overly long-winded. But he called back then in 6 months, and his salary had doubled, and he'd had 2 promotions, and he was just on top of the world. And I never spoke with him again after that.
Yeah.
And I always wondered what happened to him. And then he sent me a Christmas card about 3 years later. And he says, "Dr. Burns, I hope you still remember me. And I just wanted to give you an update." It was a Christmas card then with a note on a piece of paper, a letterhead inside.
Okay.
And he says, I'm married. I have a wonderful wife and a beautiful baby daughter, and everything is going great. And God bless you and thank you for the fantastic things we did together. And by the way, Dr. Burns, I just want you to take a look at the letterhead, and maybe you'll be proud of your Ramesh. And then the letterhead was Ramesh so-and-so, president, blah, 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 corporation.
Oh.
And he had then 500 employees. He'd moved all the way to the top of the thing. And he was right originally. He did deserve to be the head of the company. But it's so sad how we sometimes hold ourselves back with depression, with anger. And what a joy it is to see that kind of transformation in somebody.
Isn't it wonderful when our patients, let us know, months and years later, how things have turned out and how we may have made a difference in their lives?
Yeah, and that's why I love the new team therapy, because even there in those days it took pretty fast. It was still probably 8 or 10 sessions before we had gotten the job done. That was pretty fast by the earlier standards, but now I often see these profound changes the very first time I sit down with someone, and that feels unbelievable to me, and it's just like getting high every time you see a patient, because when their life gets changed, it touches you, the therapist, and I get high at the same time.
Right. Yeah.
It's a fantastic blessing to be able to do this.
So do you think you could give a quick summary so that people can really grok that in our minds about, so what is that thing that you do when you do the agenda setting?
You bring the patient's resistance to conscious awareness.
Right.
And then you melt it away. I've developed maybe 15 to 18, what we call them paradoxical agenda setting techniques.
Right.
But the essence of the techniques is for the therapist to learn to become the patient, to become the patient's resistance, and to argue in an affectionate and respectful way, in an admiring way, give all the reasons for the patient not to change. In Ramesh's case, it was, why should I have to change when they're conspiring against me?
Yeah.
But you present that argument to the patient and sitting with open hands, and then the patient doesn't have to resist anymore, because you're promoting or representing the resistance in a very powerful way, so the patient doesn't have to resist anymore. Why this works in such a fantastic way, I'm not entirely clear.
Well, I'm sure some very erudite researchers might look into this.
Like the one I'm looking at now, Dr. Fabrice. No,
well,
you
thank
may
you
have
so much.
some theories about it.
I'm more of a clinician than the researcher, but yes, thank you so much, David. So, so you said that you have a number of paradoxical agenda setting methods, and I'm sure that we will talk about some of those in the future. It's good to know that you have.
Yeah, if we come back to it, I've got some
arsenal.
other fantastic vignettes too, paradoxical agenda setting, funny ones and inspiring ones, but that'll be for another day.
One thing that I noticed is that you said that you become the patient.
Yeah.
In other words, even though you're past what we call the empathy phase, you're still being empathic, because you're really putting yourself in the patient's shoes.
Yeah, it's a deeper form of empathy.
Absolutely.
And it also involves the kind of the death of your identity, and you become the patient temporarily.
Yeah, it's
and the patient then has to heal you, and so the patient is healing himself or herself through the therapist, and we do that at the empathy level, we do that at the agenda setting level, and we do that again in yet a different way at the methods level of the session. So it's the opposite of the way I was trained and the way most clinicians are trained. It's very new and different way of conceptualizing and understanding psychotherapy.
Well, that was a wonderful demonstration, David. I think that if of all podcasts we've done so far, I think this one is really a key one that people will want to bookmark.
Oh, thank you.
So I want to thank. I sure did, and I hope everyone else does. I want to thank you for doing this today. This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. Theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.